Hello, everybody. My name is Terrence Shenfield, and I've been a respiratory therapist for over 30 years. I am the former education coordinator from the University of Medicine and Dentistry of Newark, New Jersey. I am the co-owner of A&T Respiratory Lectures, and I want to thank you for joining me on my lecture on asthma airway remodeling. So I'm sure we all know about asthma, but do you know about remodeling? Airway remodeling can be defined as changes in the composition, content, and organization of the cellular and molecular constituents of the airway wall. Airway remodeling is a characteristic feature of asthma and has important functional implications. These structural changes include epithelial detachment, subepithelial fibrosis, increased airway smooth muscle mass, goblet cell hyperplasia, mucous gland hyperplasia, and the proliferation of blood vessels and airway edema. All of these things can wreak havoc on the airway, and the damage to the lung cannot be resolved by any kind of inhaled medications. So I wanted to show you more about this and teach you so you could help your patients. So I want to list the objectives of today's presentation. I'm going to first talk about what is exactly asthma air remodeling. I'm also going to talk about the evidence supporting it. I'm going to talk about the pathophysiology of asthma airway remodeling, and I'll also talk about some treatment options. This is a very important characteristic of asthma, and almost all patients with asthma has various degrees of it. So you may ask, what is asthma airway remodeling? It was first described back in 1922 by Hubert and Kosler in fatal cases of asthma. What they did is they had patients who died of asthma attack, and they did a biopsy on them, and they actually looked at the lungs. And they found a bunch of different histological changes in the tissue of the lungs versus an average person. So what they did was they compared histological slides of these patients with asthma air remodeling versus a normal person, and they found that these patients had structural changes in the airway. For example, they had what is called subepithelial fibrosis. They had mucous cell, goblet cell hyperplasia. They had what you call epithelial hypertrophy, characteristic of airway remodeling. They had structural changes in the basement membrane. And what they found was they believed that this was caused by long-term inflammation. So as we know, asthma is an inflammatory response to the lung, and as a result of this constant inflammation, you get these structural changes. The problem with it is that once these structural changes occur in the lung, you cannot really manage it by beta agonists or different types of respiratory medications because there's a structural change. You have basically this fixed obstruction in the airway, and this can lead to serious consequences later in life. It actually impacts both the small airway and the large airway, and it starts right away. So in other words, there's various degrees of airway remodeling, and as time goes on, the damage gets more and more. So how do we determine whether someone has asthma? And then again, how do we determine if someone has airway remodeling? One of the hallmark signs of determining asthma severity is to do an FEV1. An FEV1 is forced expiratory volume in 1 second. So basically what you do is a forced vital capacity, and you measure the amount of flow that comes out in 1 second. Another way of doing it is to look at asthma scores. When you're an asthmatic, you are diagnosed with asthma, and then you're also diagnosed what kind of severity score you have. You could be intermittent, you could be mild, you could be moderate, or you could be severe persistent asthma. And based on the score, that is your treatment plan. And you could almost guarantee that when patients are moderate to severe persistent asthma, they most likely will have some form of airway remodeling. Another way of looking at it to see if you have some kind of airway remodeling is to look at fixed airway obstructions. And if you do a pulmonary function test and you do a forced vital capacity or slow vital capacity and you see a fixed airway obstruction, that might lead to the suspicion that you have airway remodeling. So that's another way of determining it. So even if you give a bronchodilator, you're not going to see a change in your FEV1, and you're going to see the same kind of flow waveform for a fixed airway obstruction. Another way of looking at it is to do a CAT scan. A CAT scan will reveal thickening airways and increased proportion to disease severity. So what that means is you're going to do a CAT scan and you're going to see the thickening of the airways, and you could assume that the thicker the airways, the more severe the disease is. And then the final way is actually you could do bronchial biopsies, where they actually take some tissue samples and they examine it under a microscope, and they could determine how severe is your asthma, and especially when we're looking at airway remodeling. This is a great slide to talk about how airway remodeling impacts your lungs. This is a tissue sample from the lungs, and as you can see, you have your mucus, and then underneath the mucus you have your columnar cells with these little hair-like features right there, which are called cilia. When you get airway remodeling, the cilia is damaged. As a result, you cannot mobilize the mucus that's on top of the lung lining. So as a result, these cells right here are columnar cells. They do not have cilia, and as a result of not having cilia, they actually cannot mobilize any kind of antigens through the mucus. Another thing you may want to notice is that the goblet cells, which are right here, this is a goblet cell, they are greatly enhanced in size, which is called hyperplasia. When they get bigger, they produce more mucus, which again results in more problems. Another thing I want to bring your attention to is the mucous gland hypertrophy. What that means is this gland right here, which is really oversized, typically it's not that big, produces excessive mucus. You get subepithelial fibrosis right here. You also get this tissue, this part right here is your muscle tissue. And for some reason, the smooth muscle mass increases in size, and the diameter of the airway narrows as this happens. You also get what is called angiogenesis, which is basically you get vascularization in that area, and that could create edema. So all of these factors result in increased mucus, number one, and number two, increase in diameter size, which impedes airflow. So all of these components work as part of airway remodeling, and I'm going to go a little bit more detail as we go along. Let's talk more about the evidence of remodeling. Dr. Peter Jeffrey, he reviewed histologic slides of patient samples under an electron microscope. And what he noticed, like I explained before, was epithelial damage. He actually showed thickening of the reticular basement membrane, increase in mucus glands and goblet cell size, increase the number of blood vessels, which is called angiogenesis, and an actual increase in smooth muscle. Why this is important is because as these cells increase in size and you get increased smooth muscle, you narrow the airway. And when you narrow the airway, you have restriction, and that's why you have a hard time breathing. When you give a nebulized treatment, it doesn't work for this because you have some physical changes to the airway. He also showed that there was an 18% increase in myofibroblasts 24 hours after an allergen test. What that means is if the airways are subjected to an allergen, something they're allergic to, there was an increase in muscle cell growth by 18%. And this leads to inflammation and remodeling. It also leads to narrowing of the airway and restricted breathing. So he did a lot of good work with this, and he showed how airway remodeling is so important and how to avoid it. So I just wanted to show you some more features of airway remodeling. For example, goblet cells and mucous gland hyperplasia, which means that these cells become bigger. As they become bigger, they hold more sputum. And when you have more sputum in your airway, this actually results in airway narrowing. You also have an increased smooth muscle mass. I was telling you how the muscle tissue grows in response to allergen, and this actually increases the inflammation process and also the asthma severity. Another thing you might want to look at is angiogenesis. Angiogenesis is when new blood vessels, veins and arteries and arterioles, they all form in this new muscle tissue. So the excessive growth of vascularization in that area increases the likelihood of edema, which again narrows the airway. And then you have what is called subepithelial fibrosis. And basically what that means, you get some fibrotic changes to the airway, and again, adding to narrowing of the airway. And then you get the epithelial alteration. And what that means is basically the cilia that's on the columnar cells is damaged, so they can't mobilize mucus and allergens that are on the airway, so you lose that protective mechanism that you normally have. So why does airway remodeling happen? First of all, you need to have asthma. This doesn't happen if you don't have asthma. So asthma can be described as either intermittent or persistent. It could also be further classified as being either mild, moderate, or severe. The longer you have asthma, the more severe your case, the more likelihood you're going to have airway remodeling. The most common symptoms of asthma include smooth muscle contraction and inflammation, which actually narrows the airway, which causes difficulty in breathing. There are numerous triggers that can cause bronchoconstriction, such as allergic responses, such as if you have a postnasal drip. It could be respiratory infections. It could be exercise induced. It could be irritants. It could also be caused by non-steroidal anti-inflammatory drugs with certain patients. Thus, asthma has various variants what causes it. So the problem is, with the greater amount of medications you take for your asthma, the greater likelihood that you might develop into airway remodeling. Chronic inflammation is another big problem with it. When you have chronic inflammation, there are some pathologic features that change, such as epithelial injury, infiltration of inflammatory cells. These inflammatory cells include eosinophils, lymphocytes, mast cells, and phagocytes. When these type of cells are brought to the airway, they release all kinds of different inflammatory mediators that causes chronic inflammation. Some of these mediators are cytokines, and the cytokines are released by the T cells. You get pro-inflammatory cytokines that amplify the inflammation response. You get chemokines, which actually attract leukocytes to the area of inflammation. And you also get growth factor. Growth factor actually promotes cell survival. All of these things lead up to airway remodeling. Over time, persistent changes in the structure of the airway occur, such as epithelial fibrosis, mucus hypersecretion, goblet cell hyperplasia, epithelial cell injury, smooth muscle hypertrophy, and angiogenesis. So this is the reason why it happens. So the question is, what do you do about it? Let's talk about the epithelial alterations and clinical impact. What I mean by epithelial alteration is I'm talking about your columnar cells. Your columnar cells are the cells that are just under the mucus of your airway, and on top of these columnar cells you have your cilia. The role of cilia is to actually mobilize the mucus that is in your lungs. The role of mucus is to catch allergens. So if you breathe in some form of allergen like pollen or something like that, it attaches to the mucus, and then the cilia cells just move and mobilize that allergen out of your airway and you cough it up. This is a very good thing. But with airway remodeling, those cilia are damaged or killed completely. So what you get what is known as called epithelial shedding. Another problem is you get what is known as goblet hyperplasia. As mentioned before, hyperplasia is increased in size, and the role of the goblet cell is to produce sputum. So if these cells become bigger, they increase too much sputum in your airway. So the clinical applications of this is, number one, you lose your protective barrier against allergens. Another thing is you end up getting airway narrowing, and also the airway gets rather thick. So this is a very important aspect of what's going on with airway remodeling. Let's talk more about subepithelial fibrosis. Basically, under the columnar cells, there's this basement membrane called the subepithelial area. And this area actually ends up becoming thicker with airway remodeling. And the reason it becomes thicker is because what is known as extracellular matrix proteins are actually deposited in this area, resulting in increased thickness. The problem with that is it increases the asthma severity because it becomes thicker and the airways become narrower, and this is not relieved by any kind of bronchodilator. This area becomes thicker, it becomes narrow, and it becomes obstructive with breathing. And this is what is known as subepithelial fibrosis, and this is another clinical part of airway remodeling. Let's talk about the role of increased smooth muscle mass and its impact with airway remodeling. The normal airway, with the image on the right, shows that the muscle tissue is not excessively large in a normal airway. But with airway remodeling, you actually have an increase of smooth muscle inside the lumen of the airway, and as a result, you have narrowing. Basically, when you have airway remodeling, the smooth muscle mass is increased by two methods. One is called hypertrophy, which is actually the size, and then the number of muscle cells, which is called hyperplasia. Also, during airway remodeling, the smooth muscles migrate to subepithelial area and they increase in size. These smooth muscles also participate in inflammatory responses in the body by releasing pro-inflammatory mediators such as cytokines and chemokines. Chemokines have the ability to induce other muscle cells to come to the area and also to increase in contractility. This all contributes to airway obstruction. Another part of airway remodeling is called angiogenesis. Angiogenesis is quite simply an increase in vascularization in smooth muscle. So as the image shows on the right, before angiogenesis, you have this vascularization feeding blood supply to different parts of the lungs, especially the airway. And after smooth muscle increase, you actually have this greater vascularization there to supply blood. The problem with that is this abnormal amount of blood supply to support this new muscle tissue actually increases airway edema. It increases airway edema, it reduces the wall caliber, and it actually increases inflammatory responses to the airway. So angiogenesis is not a good thing in airway remodeling. In asthmatic patients who develop into airway remodeling, there's a problem with two types of cells in the body. One of those cells is called the goblet cell, and the other one is the mucous cell. They end up increasing in number. Increasing of numbers is called hyperplasia. So the goblet cells increase in number and the mucous cells increase in number, and the resultant factor is that they produce too much sputum. As a result of damage to the cilia and you cannot mobilize secretions, and now all of a sudden you're producing more secretions, this has a negative impact on the airway. Basically, you end up having airway narrowing due to the sputum secretions. You end up having increased airway wall thickness, and all of these inhibit the flow of gas in and out of your lungs. This is a very important slide in regard to airway remodeling, and this is the role of airway cartilage. You all have heard of cricoid cartilage, and what that means is that our bronchi have these cartilage rings around the airway, and the integrity of these rings actually keeps the airway kind of stiff. So what you have is when you have these rings like this one, or this one over here, or this one over here, they actually keep the caliper of the airway open and they don't collapse because they're kind of stiff. But because you have a decrease in cartilage volume and an increase in cartilage proteoglycan degradation, you end up getting increased bronchoconstriction. What that means is that cartilage is made from proteins, and the proteins degrade quicker and they don't produce as much, and as a result they become kind of flimsy and they collapse when you breathe in and out. So if you take a breath in, that cartilage will shrink, and that narrows your airway, which is another very important factor of how airway remodeling works. The role of inflammation in asthma cannot be understated. Asthmatic patients really suffer from inflammation. Inflammation is what really causes the airways to swell, and also at the same time it causes remodeling properties. When an airway is subjected to some form of allergen, eosinophils, mast cells, and lymphocytes migrate to that particular area in the airway. Once they reach that area, they release all kinds of inflammatory mediators, and these inflammatory mediators cause bronchoconstriction. They also cause an increase in mucus secretion, and most importantly, cause some kind of remodeling. This all correlates to what is known as Airway Hyper-Responsiveness, and AHR, and that is increased with this type of process. Studies have shown that interleukin 11, interleukin 17 have potent remodeling properties. Those two mediators have been shown to really have an impact on the remodeling properties of the lung. Also, histamine participates in airway remodeling through an increased fibroblast migration. So inflammation and asthma go hand in hand, and controlling the inflammation is one of the best strategies you can do. Long-term consequences of asthma and airway remodeling have an impact on lung function. Lung function can be measured by pulmonary function test. Due to the structural alterations in inflammatory processes, the shape of the lung changes. Basically, the morphology of the lung changes to a point where you get fixed obstruction. When you have fixed obstruction, even with bronchodilators and an anti-inflammatory medication such as steroids, it doesn't change it. So the only way to change it is through a surgical procedure, which we'll talk a little bit later. So there is long-term dysfunction of the lung, and these structural changes cause fixed obstruction as measured by pulmonary function test. Studies have shown that allergic rhinitis and asthma have a direct relationship. What they have found that if someone has allergic rhinitis, there's a threefold chance that they will develop asthma. And if you develop asthma, you will end up having airway remodeling. So one of the key points to do is control the rhinitis. And some of the mainstay drugs of controlling rhinitis is montelukast and antihistamines. Basically, you could use a nasal spray, and if you improve the rhinitis, you actually will decrease the likelihood of getting asthma, and also at the same time not getting airway remodeling. There was a study by Chakar where they looked at structural remodeling abnormalities. I'm talking about subepithelial fibrosis and increased myofibroblast, and they found that patients with allergic rhinitis had an increased likelihood of getting the structural abnormalities. So really, the take-home point right here is if you have rhinitis, control it, and you'll have a less likelihood of getting asthma and also asthma airway remodeling. My son, Jordan, actually had rhinitis, and he really had some mild asthmatic symptoms. So as a young kid, we ended up taking him to an allergist, and they started immunotherapy. Immunotherapy is a treatment where they give you some kind of allergen, and they increase the dose of that each time they see you, and the goal is to develop some kind of immunity response to the inflammation. And they have shown that immunotherapy works very well with patients with moderate to severe allergic rhinitic subjects. So basically, you're controlling the rhinitis, like I said on the previous slide, and this will control the asthma. But this is really a good therapy, and it worked very, very well for my son. So I'm happy to hear that. How about the use of corticosteroids and airway remodeling? There's some real good evidence showing that if you use corticosteroids as the management strategy for your asthma, the likelihood of getting airway remodeling is greatly reduced. Corticosteroids is the hallmark of controlling asthmatic symptoms. Basically, corticosteroids decrease the inflammatory process of the lung, and it could influence how airway remodeling occurs long term. Studies have shown that there is not an increase in basement membrane, there's no increase in muscle mass in the airway, and so the use of corticosteroids is very, very important. Any asthmatic patient should be controlled with corticosteroids if they show benefit. And one of the biggest reasons why patients go into status asthmaticus is because they don't manage their airway, and they manage their airway with a bronchodilator rather than a corticosteroid. So good studies showing that corticosteroids are good for airway remodeling, and if you have any kind of asthmatic condition, you should really control it with an anti-inflammatory. In airway remodeling, there's a very good drug out there, and it's called montelukast. Montelukast is an antagonist leukotriene, which has been shown to decrease the inflammation of the airway, as well as decrease allergic rhinitis, and therefore airway remodeling. Asthmatic patients with nasal polyps really treated with montelukast respond very well, with a 70% improvement in nasal symptoms. This correlates to a 60 to 90% improvement in clinical asthma scores, which is very, very important. How montelukast works, it actually decreases sputum eosinophils, which, as mentioned before, eosinophils are part of the inflammatory mediators of the lung. So montelukast has very good anti-inflammatory effects, and very important part about the pathogenesis of airway remodeling. So this is a good choice when you have asthma and rhinitis. Some other great things about montelukast is, number one, it's been shown to inhibit smooth muscle hyperplasia. And the role of smooth muscle hyperplasia is the fact that the airways become swollen with muscle tissue, which actually limits the airflow. Another thing, mucus gland hyperplasia, which is all about decreasing the amount of mucus that is going in the airway, because this hyperplasia makes so many cells of mucus glands that they really block the airway. And finally, epithelial fibrosis or subepithelial fibrosis. And basically that thickens the membrane and actually keeps the airway really kind of stiff. Studies have shown that with montelukast that lymphocytes and myofibroblasts diminish after 8 weeks of use. Myofibrous cells are the precursors to muscle cells, so that's how they work. Also, human studies show that anti-leukotrienes prevent airway remodeling of goblet cells. And remember, I told you about the smooth muscle hyperplasia. and really works very well. So long-term studies are needed to confirm the clinical outcomes of the anti-remodeling effect of leukotriene receptor antagonists, but I would say this is one of your real go-to drugs to prevent airway remodeling. Some patients with allergic asthma respond very well to a new medication, which actually goes by the brand name Xolair. Xolair has been used in over 90 countries across the world, and is basically for severe allergic asthma that doesn't really respond to corticosteroids or antihistamines. It's approved for patients who are 12 years and older with severe to moderate allergic asthma, and it's been shown to be very effective. Xolair is a recombinant DNA-derived humanized monoclonal antibody that specifically binds to human immunoglobulin IgE in the blood and interstitial fluid, and to membrane-bound forms of IgE on the surface of B lymphocytes. In plain language, this medication works very well with patients who don't respond well to steroids or antihistamines, and it also shows that it reduces levels of circulating cytokines, interleukin-5, interleukin-13. It improves lung function with these patients, and it's really a good choice with patients who don't respond well. So what's the role of a beta-2 agonist and theophylline with airway remodeling? Albuterol is very good for reducing airway muscular tone. It actually improves expiratory flows, but it has very little effect on airway remodeling. So if you use a beta-2 agonist as a controller medication for long-term use with asthma, you're going to actually create more harm. The best thing to use is an inhaled corticosteroid. They did a study with salmeterol and an inhaled corticosteroid, and they found that it reduced the number of vessels in the lamina propria compared to patients treated with corticosteroids alone. So it had a little bit of benefit as a combination. Theophylline has no effect at all. So if you use theophylline, it's not going to impact airway remodeling, and you might want to consider other treatment options. There are some new therapies under investigation for the use in airway remodeling, and it's kind of surprising that some of these medications have nothing to do with asthma medications, as to say. So the whole purpose here is to influence the inflammatory process of the lung. So basically, because asthma inflames the airway and creates all this physiologic havoc to the lung, the goal is to sort of decrease that inflammatory process. And they actually doing some research with 4 different treatment options. One of them is Bacille Comente Guerin vaccines, and you may know that vaccine because that vaccine is the same vaccine used for tuberculosis. And what they found, that it was capable of switching the immune response, thus reducing inflammation and remodeling in the airway. So it's kind of funny. Here you got an anti-tuberculosis medication, and it's actually doing very well with your immune response and actually decreasing inflammation. Another targeted research is interleukin-5 antibodies, and basically what they do is they target the eosinophil, and the eosinophil, especially eosinophil-mediated inflammation, and there's been some good studies showing that it's been working rather well. And finally, we get into Rampant Myosin, which is a macrolide analog, basically that is an antibiotic, and they found that this antibiotic actually has immunosuppressive effects and can influence inflammation and remodeling. And they've done some studies with mice and other animals, and I believe they're working into human trials, but again, it decreases the inflammation. And finally, we get to the last one, which is a phosphodiesterase inhibitor, a PDE inhibitor, and basically that works on 2 pathways. Number 1, it's anti-inflammatory, and the second part is it actually is a bronchodilator. And they are doing some research with this medication, and it's been very promising. So the time of this presentation, they might be doing some new stuff with this, but this is what's in the pipeline for airway remodeling. As I've been explaining through this lecture, the concept of airway remodeling is that there is structural damage. Basically, there's morphological changes in the airway with fixed obstruction that is not relieved by any kind of inhaled medication. So a process has been developed called Bronchothermoplasty, which is basically a procedure where a catheter is inserted into different segments into the lung, and then a radio frequency is emitted that actually burns some lung tissue. And the tissue that they target is actually the muscle tissue, the smooth muscle tissue. So the goal of this type of procedure is, number one, to insert it into different segments into the lung and then emit this radio frequency. And then what it does, it removes some of the smooth muscle tissue and actually makes the airway more normal. As a result of this, your pulmonary function test returns to normal and your severity of asthma is actually greatly reduced, and it's actually been shown to be a very promising procedure. The problem with this procedure is extremely costly. Not costly. All right. So I thought I would show you some images that show you how the procedure works. And actually, it's done through 3 different levels, and it can be done at 3 different times. Basically, in procedure 1, they actually go down to the right lower lobe. And then in procedure 2, they go down to the left lower lobe. And then finally, on procedure 3, they go to the upper lobes. And as you can see on the upper right-hand corner, it actually goes into the bronchi of the lung, and then that's where the device actually emits this high-frequency burning apparatus that actually burns the smooth muscle of the airway and actually relieves that fixed obstruction like I was telling you. This was a trial that was set. It's called the AIR-2 trial, and basically they looked at how bronchial thermoplasty really worked, and they looked at 12 months of real data. And what they found that patients who received the procedure, which is in the light gray area, they ended up having less severe exacerbations of asthma. They also had unscheduled physician office visits. It was decreased. The emergency room visits for an asthma attack or status asthmaticus was greatly reduced, and hospitalizations were greatly reduced. So there's really some strong evidence showing that if you do happen to have airway remodeling and you do get this procedure, the likelihood of you recovering and actually doing much better is extremely high. I want to thank you for joining me for my presentation on airway remodeling. I find this is a very interesting subject, especially for those who treat asthmatic patients. If you need some good references, these are some great references listed right here. And be aware when you're treating patients who have asthma and they don't respond to bronchodilators and they got a long history of asthma, you could strongly suspect there could be some airway remodeling, and they got to be diagnosed by the methods shown in the previous slides. I hope you have a great day.